I think welcome everyone. Some of you may remember me from when I was in active practice, but I'm still in active practice on Gecko. And it's my pleasure to welcome you to this Gecko Fellows session, which I sort of half hijacked from Mashiko and Reed, so we could introduce you to hopefully a new asset that we have in the form of David Tate. I'd like to just state that this is supported by G-ECHO from the Gastro Foundation, who are obviously part of the parent ecosystem in New Mexico. It runs every second Monday at this time. And just remember that this is meant to be interactive and that you can populate the chat box and we will monitor it. It's my great pleasure to introduce David Tate and to recognize that his involvement with us has largely been brokered by Vikesh Lala, who is there as a visiting fellow in his unit. And to give you some background on David, he looks very much younger than me, and indeed he is. And he's really an interventional endoscopist of note. He trained in Cambridge and then went to one of the leading centres for those of you who follow how to take polyps out by Professor Michael Burke, and did his PhD there. Sub-interest is the treatment of early gastrointestinal malignancy. And so where better to start than looking at how to recognize, characterize, and decide what to do about pre-neoplastic lesions or neoplastic lesions in the colon. David's renowned for his teaching and has been the inaugural founder of GEEKS, not spelt G-E-E-K-S, but it has a different acronym. But essentially, this is an educational program that seems very well founded, and we're looking forward to his interaction with us and your interaction with him. I will play a very passive role in the interchange. So over to you, David.
Thanks. Thanks very much, Sandy. So we've got a quick bit of introduction, by way of introduction, a few slides. I don't know, hopefully everyone can see my slides here. And then we're going to delve into lots of examples. So Vikesh and I have prepared some examples. I think we're better to go with this than real life examples. And we will take you through them step by step. But first of all, to understand anything really in life, you need a structure. And I think that's where we're going to start. So why is it important to know about how to image colorectal polyps? Well, we know that there is unexplained and unacceptable variation in polypectomy practice throughout, particularly the Western world, where this data comes from. There are people being sent for surgery for benign polyps. There is cancer happening because people are not following up their polyps properly and not resecting them properly. And there is just our general observation of what's happening in clinical practice. Here you see a polyp remaining a few days after a polypectomy, and you can clearly see the polypectomy site is not clear. Here you can see a large recurrence within a scar. Here you can see a very bad attempt at polypectomy, which probably means the patient has to go for surgery immediately rather than later on, because the person who's doing the polypectomy has not been able to complete it. And here you can see the opposite end of the spectrum with a nice, beautiful scar when polypectomy has been done properly. We have some evidence, this is one particular example, to suggest that a lot of surgery has been done for benign polyps, and we would argue that that comes down to imaging of polyps. And we might suggest that in this nice article from Roland Valori, that actually post-colonoscopy colorectal cancer, the thing we must avoid when doing polypectomy and colonoscopy, certainly some of it can be attributed to doing polypectomy badly. So previously in the course, we asked lots of people what they wanted from imaging, and I show this to you just because actually I think it's interesting in terms of this. But the majority of it is how do we do polypectomy, not how do we image polyps. And everyone wants to know about the doing, and nobody wants to know about how to assess a polyp properly. So unfortunately today, we're not going to give you any of the doing, and we're going to give you all of the imaging. So this might be how you might look at polypectomy if you did a bird's eye view. And there are some key decisions you make when you do polypectomy. So what is the risk of cancer in the polyp? What technique should I use to remove the polyp? And then only then is it how to cut out the polyp, and later on how to assess the quality of it. And so today we really will be focusing on the top part of this algorithm, which is how to see if a polyp contains cancer and match it to the endoscopist. So we'll skip that. Let's consider these polyps. Each one is a zooming in of the other. Another one, zoomed in, another one. And all of them contain a demarcated area. Now, a demarcated area is, just as it says, an area that is bounded by clearly that you can draw around it within each one of these polyps, and it signifies the presence of a problem. It doesn't always mean that that polyp contains cancer, but it's something that should direct your further attention. Here we have a chart about lots of different ways which people have worked out over the years of figuring out whether a polyp contains cancer or not. But I would suggest to you that none of that is very useful in everyday practice, because it's quite difficult, it's quite cumbersome, and it's quite annoying to use in clinical practice. So I would suggest that this is really all that you need to know. When you look for and find a demarcated area within a polyp, which you think may be the area which might contain cancer, then this is what you need to know. So you all know, hopefully, the NICE classification, but if you don't, NICE 1 is using virtual chrome endoscopy, narrowband imaging, BLI, FICE, any of the different provider algorithms. That NICE 1 is lighter than the background, as you can see here. NICE 2 is the same color as the background and mainly regular, and NICE 3 is the same color as the background, but disordered. And then the Japanese, because they always do, they're into the detail, changed this a little bit and changed NICE 2, separated it into 2A and 2B. Now you might say, well, you're telling me another classification system, that's making everything really difficult, but it's not very difficult, because actually just replace the names JNet with these terms: regular background, but darker. So regular background, but lighter, regular background, but darker. And then irregular with some structure, and you can see that indeed there is some structure maintained, but it's not as regular as this pattern here, and completely irregular. And so that is what we're talking about when we look in a demarcated area, and we will show you multiple examples of that as we go along. But that is a structure that you can use to analyze any demarcated area within a polyp. And of course, what does this correspond to? The hyperplastic or serrated type polyp, the adenoma with a regular area, the irregularly regular area, you could say, at risk of invasion, maybe high-grade dysplasia, and the completely irregular, deeply submucosally invasive. And very nicely, this separates into those polyps which need endoscopy or can be treated with endoscopy on the left, and those with surgery on the right. So we'll do some examples. I mean, Vikash and I have got some examples going on later, but this is just one to take you through what we're talking about. So I need to turn off the sound, or that would be better if I was talking live and not on the thing. So you can see here, and I'll just do this one. You can see here a polyp, clearly a polyp. You can clearly see that there's something wrong with the center of the polyp. So this area here within this polyp is not the same as the area around the outside. So you might agree with me that we can call this a demarcated area, as in demarcated different from the rest. And so the question is this demarcated area regular? Is it irregular with some maintained structure, or is it totally irregular? So we go on to have a better look. And normally for looking at that, just ignore these things above. These are previous polypectomy sites. while we're going along, to get the answer to the question about the demarcated area, we need to go in closer. So you'll see that happening here as the endoscopist gets closer, and we need to see whether we think there is maintained structure within that demarcated area or not. So we can use water for that. You can use water and a cap if you're not sure. And here we see it. So now we start to see it nicely with white light. And then as you go in closer, maybe you can clearly see the edge of the normal looking polyp. So this certainly would be a regular structure. And then here you can see the abnormal area. And so to get an idea of the structure, it's better to use virtual chrome endoscopy because you can see the blood vessel pattern. And here we see it, right? So here we clearly see the pattern. And if you can take a still image of this sort of area, then you can get a very good idea about whether or not that is deeply invasive or not. And so I would argue here that this structure is disrupted, so it is irregular, but it has some maintained structure. So this is a irregularly regular demarcated area. And if you want to talk technicalities, that will be JNet 2B, and therefore you might think that there is high-grade dysplasia or early cancer within this polyp, but it certainly would be a target for endoscopic resection. The other ones we'll do later. Just to say, a demarcated area may not always be cancer. So you might look in that demarcated area and you might see that there is completely regular pattern. And here you might argue that you look from afar, you clearly see a depression, often associated with a demarcated area, but that area, when you zoom in, does not contain an irregular pattern. And so indeed, this is a demarcated area, but doesn't have evidence of a regular pattern and is therefore not a concern for cancer. Another example of that can be seen here. All right. So then we might say, well, how do we assess such polyps? Well, actually, if you find a demarcated area, then you go down the route we've just described and you look at the demarcated area. But if you don't find a demarcated area, then we are talking about, is there still a risk of cancer within this polyp? And there is still a risk of cancer within polyps which don't contain a demarcated area. Why is that? Because if you have a nodular polyp like this one here, the cancer can be buried beneath the nodule and can be invading into the submucosa from underneath the nodule. But as the endoscopist looking from above, you may well not see it. Whereas in the other example here, where the polyp is depressed and clearly has a demarcated area, you can see the cancer in black on the surface. And so there are 4 factors which determine the risk of there being cancer buried under the surface of a polyp. Those are the size of the polyp, they are the location of the polyp, they are the granularity of the polyp, we'll come to that, and they are the Paris classification of the polyp. This is a little bit our algorithm of how we might get into it, but first of all, we will just take you through the examples of COVID. Hopefully, no, we won't. Okay, so we will just come back to that, but to impress upon you that some of these things here can definitely change the risk of cancer within a polyp if you don't find a demarcated area. And while we're doing the examples that we're about to come to, because I really want to make this interactive, then you can follow along yourself. So I think we sent you a Word document which you can fill in, but if you don't have that, then you just have to go to geeks.com /SMI, and you will be able to follow along and do all of the scorings with us during this presentation, because in a minute, we're just going to show you a load of videos and take you through the structure. And that is how to use that tool. And here are some more examples, which we will come back to later. So that's a little bit about imaging. We will talk to you about the what granularity means and the different examples of how to apply that in examples. But I want to say one other thing, because it's not just about imaging of polyps in terms of cancer risk. It's also about, should I be doing this polyp or should somebody else be doing it? Should I just make an attempt at this polyp or should somebody else be doing it? Or should nobody be doing it and should be for surgery? And the for surgery question, I think, is certainly based upon endoscopic imaging. for cancer. But the question about the endoscopist is not well covered by what I've just told you. So I've just told you a whole load of ways focused on a demarcated area and some other characteristics of polyps which increase their chances of cancer to decide whether a polyp has cancer. But I haven't told you how to decide whether to do a polypectomy based upon your competency or the perceived difficulty of the polypectomy. So there are two tools which can be used to somewhat objectively assess how difficult a polyp will be to remove. You first have the SMSA score, so the size, morphology, site, and access score. It's made up of these components. The morphology here is sessile, so less than 2.5 on the mucosa, or pedunculated. It's left or right colon, and it's easy or difficult to access. And this gives you some points, and this converts into a score of 1 to 4. And that score tells you how difficult it is, 1 being easy and 4 being difficult. So these things are clearly what makes polypectomy difficult. We just have to think about it in the right colon, bigger, more difficult access. And it turns out that indeed these do predict very much the success, even amongst experts, of how well polypectomy goes. So if you just look at this study, loads of lesions, expert center, and the SMSA2 versus the SMSA4 polyps are less successfully removed, have more bleeding, have more delayed bleeding, have more surgery at 2 weeks, and have more recurrence than the SMSA2 polyps. And so you can see some examples here of the different types, and you can see that this polyp, SMSA4, would take experts median duration 30 minutes, likelihood of success 94%, delayed bleeding 7.8%, recurrence 23.7%, and then look at the SMSA2 lesion, takes them 10 minutes, very high likelihood of success, very low delayed bleeding rates, and recurrence rates almost 4-fold less. So this is to impress upon you that it's not necessarily that that lesion is going to take you 10 minutes, but amongst experts, even amongst experts, the SMSA score predicts how well polypectomy outcomes go. And so therefore, out in the community, almost certainly, that is even more predictive. That's available also on geeks.com. You can go and you can simply do the drop downs to calculate the SMSA score. Here we have an SMSA score of 12 and a group of 3. And also you have the SMSA plus score, which I'm just going to go on to talk about, or I thought I was. Let me just check here whether we have that. Yeah. So the problem with SMSA is that there are some polyps which are very difficult to remove. They might all be SMSA4, the most difficult end, but they still nonetheless are even more difficult than that. So this one's non-granular. We talked about granular and non-granular. The difference between a granular polyp and a non-granular polyp is that a non-granular polyp, like this one, is often just shiny on the surface. So you see it from afar, it's shiny, and I will show you some examples of granular. In fact, there is one here where it's not so shiny and it's much more bobbly, like a Rice Krispies in a bowl. So this one is non-granular. This one here is in the appendiceal orifice. This one's been previously attempted. This one is on the ileocecal valve. So there are some polyps which are very difficult, and this is this SMSA plus score, which you might say makes polypectomy very difficult. So size more than 4 centimeters, difficult location, by which we mean any of these places. Does it lift well? And if it doesn't, it gets a point. And is it non-granular over 20 millimeters? And any one of these can give you a SMSA plus score, and it only requires one of them to be a plus polyp. And these examples we are going to come back to. So just want to summarize the presentation. Hopefully we've done about 15-20 minutes of presentation, and we are going to take you through the following things. So really importantly today, we are not focusing, and I hope that you guys will invite us back to talk to you about more decision-making about hot and cold, en bloc or piecemeal, snare types, diathermy use, and technique. But today, what we want to talk about, what we want to reinforce is looking at the lesion in front of you. Is it for endoscopy or surgery? And that is really the risk of submucosal invasive cancer. It's also the difference between piecemeal and en bloc. That's really only based upon submucosal invasive cancer. And we're going to talk to you now many examples of how to make that decision. If it's for endoscopy, should I be doing it or should someone else be doing it? Because we know that polypectomy is often incompletely performed, and that puts patients at risk of complications, too many procedures, and post-colonoscopy colorectal cancer. And if it is for me today, what technique should I use and how should I best approach it? Those are for next time. All right, Vikash. So we are going to start with the videos. And so what I'm going to do is I'm going to ask for people in the audience to put up their hands maybe if they want to get involved. And so what I mean by get involved is have a look at the polyp and talk through it. But me and Vikash are going to do the first one. So that's going to make it easy for everyone. They're not going to have to be too involved, and Vikash gets the joy of doing the first one more than everybody else. So just 1 second while I just share the first video. We can, at the moment, if anyone has any questions on the presentation I just saw, then you can also obviously share that right now. Okay, so here goes the first video. So I'm going to take it through slowly, and I'm going to talk to Vikash about the structure. So remember, we didn't talk about blink impression, but there is a whole load of evidence that people's first impression matters. There's also a whole load of evidence that your first impression can be trained by seeing lots of examples of something. So the first impression of a polyp, you should train it. And my first impression now, I think Vikash's first impression is now starting to become quite reliable. And as you've seen a few more polyps, you can really use your first impression and you shouldn't go against it. Often the times I find myself going against my first impression, I'm wrong. So adding detail to the first impression almost often doesn't work. But remember, the first thing we're going to do is look and see whether this polyp contains a demarcated area. So let's watch the video. And I'll get Vikash to comment on what he thinks. So yeah, take us through it, Vikash. What do you think?
Okay, so again, like David said, just your first impression or your blink, and just eyeballing the lesion. There's no obvious demarcated area and no obvious concern for cancer. Then to just further assess it a little bit more, so looking at the paras, the size, the granularity of it. So in terms of the paras classification, it looks like a 2A lesion. It's elevated. It's got no depressed areas. In terms of the size, it's probably about 15 millimeters big. And in terms of granularity, it's a non-granular lesion.
So you said a load of very important things there, Vikash. But are they easy to interpret, the things you said there? You said it was non-granular, didn't you?
So it can be quite challenging, especially the granularity. And I think David has done some work in showing that that's the most challenging part for endoscopists to determine whether it's granular or non-granular. But I think maybe in these very small lesions, it might be less so relevant, but certainly something that you want to look at.
I think that's very important. So it's very important to notice that granularity is a
difficult to interpret component of imaging polyps, and it's probably less relevant in this situation, but unfortunately our scoring system currently contains it, although we're going to look forward to getting rid of it once we can figure out just exactly how to communicate it better to people. In any event, granularity in this case, Vikash is right, it's non-granular, and that is because when you come back off it, it's shiny and you can't really see the big bubbles within it, the big kind of nodules. And I'm not talking about a big overall nodule, I'm talking about nodules within the structure of the polyp. And we'll show you some granular ones in a minute so you can contrast. Okay, so based upon that nice analysis by Vikash, I think we've got a screen share from Vikash to have a look. And he's going to show us just now what we found. And with all these, we've mixed them with pathology results. So you can see exactly what the pathology of these polyps was as well. So you can't say that we are messing around with our endoscopic imaging. We're correlating everything we do with histopathology. And that means that you can be completely confident that what we're saying to you is based upon some microscopy as well. But soon, I think, when you've seen a few of these examples, you will get into the fact that these polyps can be diagnosed, can be characterized endoscopically. So here we go. I think I'm just having a little technical funny. Do people have questions about that one while we're waiting for the screen share?
Can I ask?
Of course.
So the edges of the polyp, to me, it looked like they were clearly demarcated. It might be that I joined late, so would you say that they are not?
Okay, we'll go back to that in a second, but Vikash let's just let Vikash show his slide of the polyp, and then we will go back to that question, because that's an important question. So this polyp was 50 millimeters in size, para 02A, non-granular in the ascending colon. And so that would give it an SMSA score of level 2. So that means the majority of people doing colonoscopy should be able to attempt this polyp. Okay, and the next one. And the pathology was, leaving us in suspense, a tuber adenoma with low-grade dysplasia. And so you should just remember that a tuber adenoma is often non-granular, and that is actually technically because the pits of a tuber adenoma are very short, and that is what makes the non-granular pattern. Okay, I'm going to go back to that question now. So you said to me that the edges were not well defined. Is that what you said? I forgot who asked the question.
To me, they look defined.
Yeah, they do. Okay. And so your question was something about a demarcated area?
I thought it was described as the edges not being well demarcated, and I thought that they looked well demarcated.
No, do you mean that a demarcated area is the edges are not well demarcated? Or do you mean this polyp? This polyp was described as the edges not being well demarcated. Is that what you said?
Yes, I think that's what I heard.
Okay, so no, I mean, I would agree with you completely that the edges of this polyp are well demarcated.
Can I just interrupt just for a second? The guys, it's obviously going to be interactive, and we want other participants from the trainees to participate, but please introduce yourself with your name and just where you're from and geographically, and what year of training you're in. It will be helpful just for the rest of the audience, and just so we've got an idea. Thank you.
Okay, so yeah, let's hear what your name is and where you're from, and then we can tackle that question further, maybe.
Sorry, I'm past training. I'm Neo Siabi from Joburg.
Okay, and so I'm still not understanding your question. Maybe you can tell me it again. If you are saying to me that the edges are demarcated, I agree with that. Is that what you were saying, or was it something else?
Oh yeah, you answered, because I said that I thought that it was described as having edges that are not well demarcated.
Okay.
And to me,
no, indeed, yeah, the edges are demarcated, yeah. But does that make a big difference here? I don't think that makes too much difference to the analysis of this polyp. It probably means it's not a serrated polyp, I would say, because it tends to be with serrated polyps, and we'll come to a few examples of those in a minute, that the edges are not well demarcated. But indeed, for the rest of most polyps, the edges are pretty well demarcated. It's mainly within the polyp that you're looking for something else that's demarcated, a bit like the edges, and then that should draw some concern. All right, so we'll move on to the next one then. And the next one is a little bit more interesting, maybe. So this one is not something we've already discussed, actually. So take a look at it, and I wonder if someone would volunteer to talk about this with me. You can put your hand up or just start talking. Someone's put their hand up. Now, who is that?
Good evening. It's Gert van der Merwe.
Hey. Good evening. Welcome. So what do you think about this one as you're watching it?
Right.
Where are you from, Gert? Maybe would you tell us first? And what year of training are you in and that kind of thing?
I'm from Bloemfontein, South Africa. I'm in the first year of fellowship in colorectal surgery.
Perfect. Okay, so please.
All right, so there's clearly a demarcated area.
There is indeed. Thank you for saying that.
We just need to get a better image on it.
Mm. In a minute, so that's not useful. We're starting to cut it out. So we'll just freeze it a bit on that demarcated area, maybe. So that's not a bad view of the demarcated area. So which side of it, the right or the left here, are you saying is demarcated?
The right side.
Yeah. What about, so the right side is a demarcated area and the left side is the normal polyp. Is that fair enough to say?
Yes, I agree.
Okay. So, all right. So then we are looking quite closely here at that demarcated area. So what do you think? Do you think it's cancer?
No, I think there's probably a high-grade dysplasia in this. It looks more or less the same. There could be areas that's darker than the surrounding areas in the polyp, but I don't think there's a cancer in this.
Okay, so I agree with that part of what you said, but unfortunately, this polyp is a bit of a hybrid polyp. So there are two areas within this polyp. As you said here, there's clearly a demarcation zone here on the right versus on the left. The left side is clearly a standard-looking polyp, right? It's very nicely structured. It's clearly regular. But the problem is that the right side.
At the top there's blood spread.
Yeah, exactly. At the right side, there is a serrated polyp attached to a standard polyp. So this is not cancer. This is a demarcated zone with a serrated polyp in it. And this is something that you sometimes see. They're dysplastic sessile serrated polyps. They are high risk for cancer. And they contain that nice demarcation between serrated polyp on the right and standard polyp on the left. How do you classify a serrated polyp? Well, they look like this. This thing on the right, so they tend to have mucus attached to them, and you see that this one did when we started. You see it there. This MBI is not useful, but when you see it in white light, there's a bit of mucus attached to it. They tend to have difficult margins to determine. So the colleague who was speaking before was saying about difficult margins, where you can see that the margins of this side, the left side, are very easy to determine, but the margins of the right side are maybe more difficult, right? It's not very clear where this ends and where the normal bowel wall starts, whereas the bit on the left is very clear. The WASP classification from Evelyn Decker's group in Amsterdam sought to describe serrated polyps in detail, and I recommend it to you, but it essentially says difficult to determine margins, lighter than the background, and cloud-like structure with lacy capillaries on the surface. And you can see all those features here. So this a little bit comes back here to what we were saying before about demarcated areas not always meaning cancer. And in this case, it doesn't mean cancer, but in the majority of cases where you find one, it will. So it's important that you make the distinction between a benign and a cancerous demarcated area. Okay, Vikash, you want to show the slide of this one? And I'll prepare the next one. Thank you, Gert, for doing that with us. Okay.
So 20 millimeter 0 to a sessile polyp in the ascending. Cancer risk up front detected low, and SMSA score 3. And pathology, sessile serrated polyp. All right.
Sorry, just to make a comment, I think just to clarify something that I think when I was here, we may have joined a little bit later, so she may have missed that section. Hi, Neil. The demarcated area principle is within the polyp and not actually the border or the margin of the polyp itself. It's to look for a demarcated area within the polyp, not the actual border of the polyp.
Important distinction. Okay, Vikash, I think you may need to unmute. Perfect. So here we have another one. I don't know if someone wants to volunteer to do this one with us. And see someone's hand up, but maybe that's one before. Anybody?
Zamo, maybe
If no one chooses, I will choose someone. Or you can choose someone, David.
Okay, I'm choosing Dr. Mzamo Bele. The only reason why I'm choosing him is because he's one of the trainees at our center, and I have introduced him to geeks, and I'm pretty sure he has some familiarity with it. So
Okay,
that's the only reason why I'm throwing him in the deep end.
Perfect. Okay, well, nice to meet you. So Mzuma, why don't you introduce yourself?
Hi all, Mzamo from Johannesburg. In the second year of my training as a fellow.
Perfect. Okay, so let's have a look at this together, Mzuma, and we'll decide together what we think. So first thing that you should be thinking is, what is your first impression? Is it cancer or not? So let's pause it because you've had time to make a first impression. Even if you don't think you have, your brain has already made its first impression. So you have to trust it. What do you think? Cancer or not cancer?
My first impression is that it's a lateral spreading tumor, not necessarily cancer at this point in time.
Perfect. That's a great answer. Lots of things in that answer which are very good. We'll come back to that in a minute. Okay, so now you're getting a bit more detail.
Okay, just looking, at the most of the polyp, looking for that demarcated area. I don't see one jumping out at me.
I agree with that. Yeah.
And then just to classify the polyp, is quite a large polyp, certainly more than 3 centimeters, maybe more. I would classify it as a 2A tumor, or 2A lesion rather. I'm not quite sure if there's an area of depression within the center. I think it might just be related to the maybe it's to the granularity rather than an actual depression. If I look at the pit pattern, certainly looks adenomatous, and vessels look look regular as well to me. So in thinking I would think this is a tubular adenoma with low-grade dysplasia.
Okay, so lots of great things in there, and some things which are not quite right. So you said to me the size is about 30. I think that's right. You said to me that it is granular. That's absolutely right. You said to me it is Paris 2A. I think, I don't know, everybody knows the Paris classification. In a minute, we'll share with you a slide of Paris classification, but it probably has some nodules in it. Can I convince you of that? Some things that are a little bit higher than the background. So in fact, that would make it 2A plus 1S, the 1S part describing the nodules. And you said to me that there was a depression in there, and then you very nicely said that you thought it might be related to the granularity. I think it's in fact just related to that fold and sitting there down there in the middle. But the key thing is, if you're worried or you're thinking about that at all, you should image that area. And unfortunately, we don't have great imaging of that area, but almost certainly you can tell, even from this suboptimal endoscopy imaging, apologies for that, that this area does not contain a totally disordered pit pattern. All right. So in summary, then we have a blink negative polyp with no demarcated area, 30 millimeters in size, 0.2A plus 1S, granular. And I think we said, Vikash, you can just share your slide because you'll tell us where it is now. And we can therefore tot up the risk of cancer within it. And if you guys aren't doing so, I would encourage you to go to the calculator and do these along with us. Ascending colon. So just before we get to SMI score, the SMSA score of this polyp is 4. So this is not a polyp to be attempting on your own at home. This is a polyp to discuss with an interventional endoscopist, and don't just make a start on such a thing, because you will end up in trouble, you will have problems, and the patient will get a negative outcome from it. Okay, just skip to the next one for me, Vikash. So indeed, as you said, it is actually a tubular-villous adenoma, because if you want to get technical, the pit pattern there is 4, or the vascular pattern is Kudo type 4, not 3. So tubular-villous adenoma with high-grade dysplasia. We didn't have the SMI score in that slide, actually. Maybe you can just calculate it. I think it's actually maybe interesting that we calculate it now on a web calculator. So while you do that, Vikash, I will share the next one. Thank you very much, Zumo from Joburg. That was very nice. I really thought it was very nice. And Vikash has obviously been teaching you something already there about that. Okay, someone else fancy this one? obviously, if it sounds like if you don't put your hands up, you're going to get chosen anyway. So you can have a go. Okay, alphabetically, it's not ideal if you're at the top, is it? But what about Cecilia? Would you be able to do this one with me, or Gillian maybe?
Okay, I'll try. I'm Cecilia, my final year of training.
Nice to meet you, Cecilia. So I'm going to play the video, obviously. Your blink impression, your first impression, just looking at that polyp, is that cancer?
I'm concerned about the depression in the center, which may make it cancerous.
Okay, so perfect. So let's have a closer look at that, because that's very important. Just if you had to come down on one side of the fence before we go further, cancer or not cancer?
Initial was not cancer, so I'm going to stick to
that's important. Okay, so stick to that, because you would be right. And it's very interesting how that goes. Anyway, okay, so indeed we need to further image the part which looks like a depression, which could be a demarcated area. So let's get a little bit closer to that. And I might just skip the video a little bit to see it. If we can get an okay. So the endoscopist obviously thinks the same as you and is trying to image. So what do you think about that demarcated area?
It actually looks similar to the rest of the polyp.
So let's go to the structure of what we want to talk about, demarcated areas. Is it regular? Or is it at all irregular?
I think it's irregular.
Yeah, okay. And if it's irregular for you, is it got some maintained structure or is it completely irregular?
There's some maintained structure.
Yeah, okay. I would agree with that. Actually, I think that's probably just the way that the thing is laying. And actually, when you come and look at it like this, it's probably actually completely regular. But I agree, yeah, if you went down the line of with some maintained structure, you'd still be doing fine with that. Okay. Maybe we can get it better with underwater imaging. Sometimes that can really help you. What about like that? I mean, that's probably the clearest view we've had of it, isn't it?
Yeah.
And would you agree that it looks pretty regular?
Yeah.
Yeah, okay. So therefore, we don't have a demarcated area for cancer. So we then need to think about the other four things which might determine the risk of this polyp having cancer. So what were those? Can you remember?
So the size, I would say it's probably about 2 centimeters.
Something like that, 20 millimeters, yeah.
And then I'd say it's non-granular.
So that's interesting. It's actually granular. So the difference, this is the clear difference between non-granular and granular. You see that the non-granular ones we showed before, they kind of are all surface shiny. And these ones, they have the little Rice. I don't know if do you have Rice Krispies in South Africa? Yeah, you know, Rice Krispies, the cereal. Well, we definitely don't have it in Belgium, but we do have it in England. These look like little Rice Krispies in a bowl. The complete opposite to the flat, shiny looking one. So this is granular. And you already said the size. So we know it's in the sea. We can see that. And the last one is the Paris classification. What do you think that is? Or if you don't know Paris, just describe it.
So, I mean, I think it's an elevated lesion. So it's probably a 2A.
Yeah, it's certainly 2A. And maybe there's a nodule here, do you think, at the top? Certainly not there, but at the top, that's just that little bit. Hold on a minute, let's see if we can find it again. See if in the distance, you can kind of see it there. On the left side, there's maybe a nodule at the left side. Do you agree with that?
Yes.
Okay, so it's probably 2A plus 1S. All right. So perfect. And therefore, we can use the calculator to get the risk, but you might be starting to get the idea that some things in the calculator are low risk and some things are high risk. So right side is low risk of the colon. Left side, mainly the rectum, is high risk. Anything with a nodule is higher risk than anything without a nodule. Bigger polyps are higher risk than smaller polyps, and non-granular polyps are more risky than granular polyps. So in this case, we have a granular, low risk, not so big, low risk, with a nodule, one high risk element in the right colon, low risk. So it's probably 1 out of 4 low risk. So let's see what Vikash can come up with for this one first, and then we'll go back to the other one, Vikash, after that maybe.
Just to take you to the SMIC, the previous one, I just put that in the calculator, which is available on the website as well. And we said it was a 35 millimeter lesion. We said it was the ascending colon, so the rectal sigmoid lesion, granular, and a 2A1S perspective. And that leaves us with a lower score of 4% for submitted cancer. Let's just get into the.
Could you guys hear Vikash?
It's very soft.
No,
Very
sorry.
soft.
Okay, so just to go over that again. This is the previous lesion, not the one that David just showed now. We didn't have an SMIC score risk, so I just plugged that into the calculator, which is available online as well on the website. And we said the lesion was about 35 millimeters. We said it was in the ascending colon, so not rectal sigmoid. It was a granular morphology, and because it had those nodules, it was a 2A1S lesion. And that gave us a total risk score of 4% for submucosal invasive cancer. So that was still classified as a low risk lesion. Just to get back to the current lesion, and that's the one.
Here.
And yeah, it was this one, yeah.
Okay, so just
so this is 30 millimeter lesions, the one we just did, indeed. So just to say, it's level 4 again. Don't attempt it at home and just go forward one. And this was achieved in something with migrated dysplasia. So indeed, you were right. No demarcated area, completely regular. And remember that this is microscopy really we're doing because we are zoomed in on these polyps very closely. So usually you can be very, very clear whether you're getting cancer or not. All right, let's do the next one. Anyone got any questions on this so far?
Can I just ask something, David?
Of course.
Yeah, sorry, I just two things. I see you use quite a bit of water and you use the cap. Traditionally, traditionally in South Africa, as far as I'm aware, most people don't use the cap for diagnostic colonoscopy. So when do you use it routinely? And we noticed that obviously you it does help very much with near focus and with water immersing the lesion. Is that also part of your assessment of these polyps? So is it routine? When do you put it on?
Well, I think there's significant evidence that you should use a distance attachment. It doesn't have to be a cap. It could be an endocup, could be anything to increase your adenoma detection rate. So I think that where funding allows, and that is a serious problem actually, even for us here in Belgium, highest healthcare spend per capita in Europe. It's still a problem to get the patients or the healthcare system to agree to adding a cap, but indeed they do, and we use it routinely for diagnostic colonoscopy. So that's answer to question number 1. Question number 2, yeah, I mean, underwater imaging is beautiful. You don't necessarily have to do it because it's not necessary to use these classification systems, nor is the beautiful imaging that we are lucky enough to have on our scopes. But I think it does help to demonstrate the possibilities. So I do use it. I don't think you have to use it to get into these classification systems, but yeah, I think it really can help. All right.
Thanks, David. Thank you.
Okay, so I'm just going to share the next example, and let's make it, let's just have a look what we've got here. See if we can, so that one we did already. So let's do the next one. So we'll skip that one, Vikash, number 5. We'll go to number 6. Yeah. So have a look at this one. So this is really a great example. And can I ask someone to volunteer? Should I need to pick someone? Gillian, do you think you could volunteer?
Hi there.
Hi, is that Gillian?
Yes, that's Gillian. Gillian from
Gillian.
Pietermaritzburg, Durban, KZN.
Nice to meet you.
I am extremely green, haven't started training as yet. I'm just in it for the interest, due to start my training in September, but I can.
Did you ever do colonoscopy at all?
No, never. This is just all brand new to me.
This is going to be a good test then of this algorithm. So remember, let's talk about your first impression, but let's also talk about whether you can see a demarcated area in this polyp as we play the video, okay?
Sure.
So first thing, people that didn't colonoscopy may think until now they hadn't seen a polyp, and I think that's fair enough. Some of these things can be very difficult to see. Again, Sandy, we are using the underwater that indeed in this case is critical. And there, maybe I answered your question a little hastily. There are some in which it's completely necessary. So what do you think?
There looks to be a slight demarcated area in the middle.
Yeah, I completely agree with you. So I wouldn't even go slight. I would take the slide off it and just say that there is definitely a demarcated area within that polyp. Okay, so if that's the case, remember from the algorithm, then we don't worry about all the other things. We just go looking at that demarcated area to see if it's regular or if it's irregular. Because if it's irregular, we stop there and we call it cancer, right?
Yeah.
So what do you think? So I've put something's different about this one. We've put dye on it. So putting dye on it for everybody else as well, that allows you to see the actual pits. So, you know, from your back in the day when you Gillian, were a lot closer to those days than me or Vikesh or anybody else, when you did histopathology and, you look down a microscope, well, what you see here is the actual pits of the colon. And what you see with virtual chromendoscopy is the vessels around the pits. But everybody talks about this who's talking about endoscopic image, and it doesn't really matter. The structures are the same. Anyway, here you will see it in the traditional way of putting dye on the polyp. So the question is this, and you can beautifully see the demarcated area here, is this demarcated area regular or irregularly regular or completely irregular? Is there maintained structure at all?
Doesn't look to be maintained at all.
Okay, and where exactly would you think?
Completely different.
Yeah, that's true. But there is one part of it where that's true, and there is one part of it where that's not true. So maybe if you could point, which I know you can't, so you could just tell me top, bottom of the demarcated area, which you think has completely lost its structure.
Probably the bottom part.
Yeah, that's interesting, isn't it? Because the reason why you're not saying the top part is because the top part has no structure at all. And in fact, it is ulcerated. And so, in fact, it's the top part, even though the bottom part, I'm totally with you, is probably, if we were looking at chromoendoscopy JNet 2B, like there is some structure there, right? But it is not maintained fully. At the top, there is no structure at all. So what you have here is you have a demarcated area, which I'm drawing around right now. Then you have the normal polyp on the outside, which you can see is beautifully regular around the outside. Then you have this part of the demarcated area, which is kind of still got a structure, but it's not fully maintained. So irregularly irregular or regularly irregular, whatever you want to call it. And here you have total loss of the structure, and it's irregularly irregular. So this is a polyp with deep submucosal invasion in it, and therefore we don't need to continue with the algorithm. We can simply say that this is a polyp which has clear evidence of cancer, and then the decision making after that is for the next time. But it's certainly something that should be removed endoscopically en bloc or sent to a surgeon. Okay, thank you very much. And Vikesh, maybe you can quickly show the slide because I think we're about to run out of time. Okay, so indeed it was with a depression, non-granular in the sigmoid. The SMI score is high. The SMSA score is level 3, but of course, if you have overt evidence of cancer, the SMSA score is not useful. And the next slide, please. Don't really see the next one. And indeed, it was cancer. It was invasive. The depth of invasion, 0.6 millimeters. The width of invasion, 0.8 millimeters. Low-grade tumor with no lymphovascular invasion and no tumor budding. So in fact, we cured this endoscopically, which is actually interesting based upon the prediction. And here you can see the final outcome. All right, Sandy, I think we're up to time. I'll just maybe you permit me to quickly say that there is much more of this available, and I'll just show you where. So I don't know where, let's just go here a minute. So if you just go to geeks.com, then you'll be on the front page, and all of these courses are here, but this is the one which has loads more examples of what we've been showing you today. And it's the first part of the polypectomy series, which goes further into how to, after imaging, goes into decision making and goes into technique. And so I hope that's given you some inspiration to go looking for these examples, which I've showed you where you can find them. I hope it's given you some idea about a structure of how to assess a polyp for cancer, and also think about whether or not you should start resecting it. Yeah. And back over to you, maybe. Vikesh, maybe you have something you want to say as a closing word?
Yeah, so just to sum up, I think you put it quite eloquently, but essentially there's two big categories. So overt cancer and then covert cancer. So overt is where your blink and your demarcated area comes in. Covert is when it doesn't clearly, obviously look like cancer, but whether there's cancer hidden underneath, and that's where your Paris +3, as you mentioned, comes into play. So it's a nice, easy algorithm to use for essentially any polyp in the colon.
Thanks very much. Thanks very much. If I can just say a few words and wind up, David. I've got. It's really fantastic that you've come on board with this, and I also come from a sort of slightly similar educational background, even though it is surgical. And so I'd like to thank you both for the effort you put in to speak to us as a South African audience. And we would very much hope that we can extend this to the sub-Saharan group that we try and service, and how to do that most effectively. Generally speaking, we're not so well resourced with endoscopes as you are generally, even within the training centres within South Africa. I think that's a reasonably fair statement to make. But I think today was fantastic, and this sort of sequential approach and the whole concept of geeks, I think is something that the trainees should really keep their eyes on, and provides them with valuable insight, especially in areas where some of us have different areas of expertise within the country itself, and some of these areas may be lacking. And perhaps for one reason or another, endoscopy is a bit of a Cinderella sport for some individuals, because we're just simply overwhelmed with volume in some circumstances. But I'd like to just say that we have been recording this, and it will be available on the Gastro Foundation website for those who haven't seen it and want to notify it to their colleagues. I'd like, obviously, to thank David and Vikesh for putting the whole process together, and for the ECHO team in India that supports us, and for the ECHO team generally. And remember, please give us some general feedback from the form that's available in the chat box. And I think at that stage, we can look forward to Geeks becoming part of hopefully a training resource for us. So once again, thanks, David. Thanks to everyone. Thanks to the participants.
Thanks for inviting us.
Cheers. Bye-bye.
Bye-bye.
Bye-bye. Thanks very much, guys, if you haven't logged off yet.